We now move on to our next presentation by Dr. Sanjeev Nair from Savita Medical College and Hospital, and he will be talking to us on the topic Gold Standards on Peritoneal Dialysis for Working Adults and Kids.
I think I'll straight off start sharing screen. Okay. Hello and welcome everyone. So the topic that I've been given is peritoneal dialysis as a gold standard for kids and working adults. We'll go straight in. Well, what are the options when the kidneys fail? And this is the question that is quite often asked by patients to us. And sadly, all the options are not always given. So theoretically, we're given three different options. We're taught three different options to our patients: kidney transplantation, peritoneal dialysis, and hemodialysis. Almost everybody is aware of hemodialysis. Your exposure and your chances of being offered peritoneal dialysis depend on a lot of factors, and therefore it's not as commonly prescribed for patients with chronic kidney disease in India. Kidney transplantation, of course, is an option always, and we can talk about it. But quickly, the most commonly prescribed option is hemodialysis. And what happens in hemodialysis is that blood passes through blood is passed through a semi-permeable membrane through which special fluid called dialysate runs in the opposite direction. The flow of blood can be adjusted via pump. The amount of resistance that we can exert on the blood can be adjusted. And all of this allows us to remove waste products from the blood which accumulate because the kidneys have failed, and also remove excess fluid in the body, which have also accumulated because the kidneys have failed. Now, hemodialysis is usually done via 4-hour sessions and can be prescribed 2 to 3 times per week. And almost everyone is aware of hemodialysis because this is the most commonly prescribed modality for renal replacement therapy in India. And we know that patients on hemodialysis have to have an access to allow for blood to flow from the body outside into the machine where it is then cleaned. This can be temporary in the form of a temporary dialysis catheter, or more permanent in the form of an arteriovenous fistula, where an artery is connected to a vein, and that allows the pressure from the artery to be diverted into the vein, thereby arterializing the vein, making it bigger, more prominent, and thicker, allowing for us to draw blood from the vein. You can also have an AV graft now, which is an artificial semi-synthetic material which can be used instead of creating a fistula. Now, the reasons for going through that preamble about hemodialysis is because that is the most commonly offered modality. But hemodialysis is associated with complications. You can have a fall in blood pressure during dialysis, most commonly. It can also have high blood pressure during dialysis. You can have cramps, nausea, and vomiting during dialysis, allergic reactions to the dialyzer and or medications that are prescribed during dialysis, fever and chills, especially when the vascular axis is infected. And the vascular axis is really the Achilles heel of patients on hemodialysis. And they can have all manner of problems, including stenosis, obstructions in the flow, thrombosis, clots within the graft or the fistula, and infection of temporary vascular axis. So all of this is to suggest that hemodialysis may not be for everyone, especially for kids. The problem is that all of the paraphernalia that we use for hemodialysis, which is the catheters, the temporary access catheters, the dialyzer, and the tubing, these are not regularly available in smaller sizes that are required for children in most centers, unless that center also regularly does hemodialysis for pediatric population. The technicians and staff required to deal with the complications that children face are again not always available. So there are logistic challenges, and they're not always trained as well. Hemodialysis can be quite safely done in children who are more than 15 kilos by weight, and for children lesser than that, hemodialysis is often not the modality of choice. And there are complications, like I said before, hypertension, your temperature is lower in infants, that causes problems. Vascular access failures that we spoke about. There's a lot of protein loss and malnutrition that can happen for children, which affects their growth. Children may be afraid of getting pricked by a needle and may require sedation for that, which requires, again, more specialized care. And the degree of dietary and fluid restrictions are much more restrictive in hemodialysis. And there is also a greater degree of loss of whatever residual urine output they have. But there are pros as well. There is less caregiver burnout because people who are taking care of pediatric CKD population are required to come along with their children or wards only two times, 3 times per week to the hospital, and they have dialysis-free days. And some kids might find it easier to attend school on a hemodialysis schedule. So all of that brings us to peritoneal dialysis, or more accurately, continuous ambulatory peritoneal dialysis. Now, as opposed to hemodialysis, what happens in PD is that the artificial membrane, the semi-permeable membrane, which we have in hemodialysis, which is synthetic, here that is replaced by a naturally occurring membrane within the body. So the peritoneal membrane is a membrane which lines the peritoneal cavity of the abdomen. Right? So this is the peritoneal cavity in which you have all your abdominal organs, your stomach and your liver and your intestines. And there is a peritoneal membrane which lines that cavity. And that membrane acts as the semi-permeable membrane. It is obviously surrounded by blood, and obviously blood supply to the peritoneal membrane as well. So the blood that flows through those vessels which surround the peritoneal membrane, that blood is what is targeted for cleaning. Now, how do we clean that blood? We clean that blood using a dialysate, specially prepared dialysis solution, which is prepared in a sterile manner so as to reduce the risk of infection. And that dialysate contains glucose, which acts as an osmotic agent, which is able to pull water, excess water, from the blood into the peritoneal cavity. So this dialysate is infused via a tube, which is surgically placed in the abdomen into the peritoneal cavity, and it stays in the peritoneal cavity and cleans the blood surrounding the peritoneal membrane, pulling water as well as waste from that blood into the peritoneal cavity. Now, at the end of that cycle of cleaning, the fluid that is already there in the peritoneal cavity is then removed out from the peritoneal cavity via the tube, and the next bag is then placed. Right? So peritoneal membrane, so CAPD acts in cycles. Each time an existing cycle of fluid which is already there in the peritoneal cavity is removed and a new solution is placed, that is called one session or one cycle. The usual time in which the fluid is allowed to stay inside the peritoneal cavity is called a dwell, and that can vary from 6 to 8 hours. The cycle continuously happens. That's why it's called continuous ambulatory peritoneal dialysis. The continuous part is because it is continuously happening. You have existing fluid removed and a new solution being replaced. And it's ambulatory because once the solution is removed and a new solution is placed, the connection is disconnected. So it takes about 30 minutes to remove existing dialysis solution and replace with a new bag. And once that cycle happens, then you can disconnect all the connectivity from the patient to the bags, and the patient is allowed to continue whatever regular activity they do. So that's the ambulatory part. So they can go to work, go to school, carry on with their regular activities of daily living. So that's where CAPD, continuous ambulatory peritoneal dialysis. Now, CAPD is performed on a daily basis, unlike hemodialysis. It is performed 3 to 4 times a day, depending on what the duration of the 12 is. And it can be performed at home or wherever the patient chooses to carry their bags with them. In addition, there is something called automated peritoneal dialysis, where which differs from CAPD. In that CAPD, the exchanges are done manually. Either the patient themselves or their caregiver does the exchanges. In automated peritoneal dialysis, the patient at night is connected to a machine, this machine, and the machine is fed the data on what kind of cycle, volumes, and number of exchanges we want to do during the night. And while the patient is sleeping, PD goes on because the machine calculates the amount of fluid that needs to be infused and the amount of fluid that needs to be removed. And that happens throughout the night while the patient is sleeping. This is obviously a lot less disruptive than either hemodialysis or even continuous ambulatory peritoneal dialysis. But there are a few patients who require a dwell even during the day, even after they're on PD, and that will vary from patient to patient, will have to be discussed with the nephrologist. But automated PD is best suited for children because it is disruptive to their schedules, and also more importantly because most children are what we call a high transporter status. Now, the transporter status is a characteristic of the peritoneal membrane. So, depending on the characteristic of the peritoneal membrane, the number of exchanges that we do will vary, and the amount of time that the patient spends on PD and the kind of modality that is used will vary. Again, this is something that will have to be discussed with your nephrologist. But most children are high transporter status, which changes as they get older from a high transporter to a low transporter status. So for a child, automated PD works best, and you can use smaller volumes and then increase according to the need of the child. These are a rough estimate. So to differentiate between hemodialysis and peritoneal dialysis, in terms of efficacy in removing creatinine, hemodialysis is slightly better. But overall, in terms of other substrates which are removed, there is no significant difference between the two. Like we said before, hemodialysis is done intermittently 3 or 4 times, 2 or 3 times a week, as opposed to peritoneal dialysis, which is done daily and via multiple exchanges per day, 3 to 4 exchanges per day. And you get intervals of days between hemodialysis, but PD, especially during continuous PD, happens continuously throughout the day. Your requirement to visit a hospital is obviously more with hemodialysis, and peritoneal dialysis is much lesser. Many of my patients come and visit me only once or two times in months. There is a need for an artificial vascular access in hemodialysis. Peritoneal dialysis does not involve the vessels. You can have just a catheter into the peritoneal cavity without any major previous scarring. There is a lot more restrictive dietary and food requirements in hemodialysis, which is lesser in peritoneal dialysis. And because the fluid removal happens slowly and more continuously in peritoneal dialysis throughout the day, the degree of fluctuation in blood pressure that we see with hemodialysis does not happen. Infections do happen both with hemodialysis and peritoneal dialysis. And in peritoneal dialysis, when the infection happens, it's called peritonitis, and it's a major challenge that we face with patients with PD. When to consider PD in children, where it is understood to be the gold standard, especially in infants, because maintenance hemodialysis is not easily available for infants, and in children who are less than 15 kgs, PD is the default modality of renal replacement therapy which is offered. In those patients, in those centers where there is, for whatever reasons, an access to hemodialysis is difficult, especially in the northeastern part of our country, there's a lot more PD happening because hemodialysis is not easily available, and the challenges for pediatric hemodialysis is much more, and therefore in those cases we can use PD. If the family prefers PD or if the support system allows PD to be considered, then PD is definitely offered for children. When vascular access is difficult to create for hemodialysis, PD is offered. And if there are other comorbidities, especially involving the heart, which make doing hemodialysis much more difficult, PD is offered. School attendance, like we spoke about, is subjective. Different children have different needs. The number of exchanges per day will impact how a child can attend school. but PD offers a lot more flexibility, and it allows for children to go to school with on a daily basis with minimal disruptions. When not to consider PD, the biggest challenge for doing PD in children is the presence of a caregiver. So someone has to be able to do the exchanges for them, and if that is not there, who can safely do it for them, then PD is best avoided in those children. And the other big problem is that you need an intact abdomen. If there are for abdominal wall defects or previous surgeries on the abdomen, which preclude someone from doing PD catheter insertion, then it becomes much more difficult to do PD in these children. So the goals of therapy is to try and do as much fluid removal as well as waste removal from children in PD, and to try and maintain near normal phosphorus as well as calcium levels. This is an important clinical target, especially for children, because it directly impacts their growth, and and abnormal phosphorus levels puts them at risk for cardiovascular disease, heart disease, as well as bone disease, impacting their growth, like skeletal growth, like we mentioned before. So PD prescription done right will allow monitoring of parameters for growth, nutrition status, and quality of life indices, including school attendance. And we target the minimum approved amount of dialysis that has to be given to children. But there's a lot more flexibility, and PD can be sort of worked around to the expectations of the child as well as the family. They can also, the child, especially if they have a significant amount of urine, can receive PD free days when they're off PD. So that's again the degree of flexibility that we spoke about. The amount of space that you remove depends on the amount of fluid that you allow into the peritoneal cavity, which is called the well volume, and the number of cycles that you do. And there is also the amount of phosphate, which we spoke about earlier, which is a very important factor how we do PD. That is dependent on the 12 time, that is the time for which the fluid stays in the peritoneal cavity. And the longer it stays, the more phosphate is removed. If we remove an excess amount of fluid, the child becomes dehydrated and can feel thirsty and nauseous. So it's important to minimize the amount of fluid we remove and to keep a close watch on how the child is responding to PD. And these are worked out over a period of time with the family, with the to figure out what works for them. And therefore it has to be individualized to each child. And that kind of flexibility in individualizing care is possible with peritoneal dialysis. So to summarize, for children, peritoneal dialysis is commonly used modality in children with CKD. Specific needs of the population needs to be considered. Access can be challenging, especially in children who are very small or who have multiple other abdominal issues. But the PD prescription can be optimized for growth and the psychosocial needs of these children. And the plan can be flexibly prescribed depending on local expertise, hardware, and economics available. Moving on to adults. So I have had patients who travel extensively with their PD bags. And if you are on dialysis, your options are between being connected to a dialysis machine 2 or 3 times per week, which means your freedom to travel out beyond the vicinity of your dialysis center is limited by the fact that you need to get back every 2 or 3 days. But someone with PD, and this is a story that I picked out from the NKF, National Kidney Foundation's website. This is a story of a patient who's on dialysis who was able to backpack through Northern California 3 to 5 miles a day while carrying his peritoneal dialysis bags with him. He stopped multiple times during the day to do his exchanges, but he was able to backpack. This is not the kind of freedom that anyone on hemodialysis can ever hope to achieve. I have patients who have business trips, who make business trips, but they take the bags with them. My patients have conducted their peritoneal dialysis exchanges in the train while traveling. All you need is a space where you can lie down or lean back, and it has to be done. machine. And as long as the steps you follow to do the extensions are done in the prescribed manner, you can actually have a great degree of flexibility and freedom even while being on dialysis. And this is what makes PD a very attractive option for patients who especially are working or have to travel for their work. So this is one of the things that have been looked at on whether peritoneal dialysis compared to hemodialysis is better in terms of quality of life. And this was one of the more recent studies done, which looked at this topic, published in 2019. And it showed that overall there were better quality of life indices scores with patients who were on PD over a 2-year follow-up. And even though over those 2 years, the scores declined for both patients on hemodialysis as well as peritoneal dialysis. Even at the end of 2 years, patients with PD did considerably better than those who were on hemodialysis. Now, this data is not conclusive. There have been other studies which show that hemodialysis is better. Overall, meta-analysis which looked at this topic have not said one is significantly better than the other. But theoretically, as well as anecdotally, patients who are on PD enjoy greater flexibility in their dialysis schedules. They have a slightly more relaxed dietary regimen because their dialysis happens on a daily basis. They are able to take care of themselves to a significantly higher degree than patients who are on hemodialysis, and there is much better preservation of whatever urine output they have as long as they are on peritoneal dialysis. And I think with that, I can stop, and I hope I am able to.
Thank you very much, Dr. Sanjeev, for so beautifully presenting on the topic gold standards for peritoneal dialysis for working adults and kids.
Thank you again.